Sorry, am I audible to you?
Yes, sir.
Hello?
Yes, sir, we can hear you.
Yeah, good morning to all of you. So my topic today is the ECMO complications, and basically I am focusing on the patient-related complications and their management. As you all know that putting ECMO in a patient is a quite complex and challenging situation because one, the patient is quite sick and then you are using a complex machines, one, not one, but two or three machines like ECMO and ventilators. So it is really challenging for ECMO specialists to monitor and to manage the complications related to the ECMO. So there's no any conflict of interest in my disclosure. And what I'm going to talk about the incidents, the diagnostic workup, and how to prevent and how to manage these complications. So if you look at for the because the complications can occur to the patient, but it's quite possible that it could be a technical complications related to the machine like ventilator and ECMO, or it could be a complication related to the cannulation itself, or it could be a complication related because the patient's clinical condition has deteriorated. So, as a ECMO physician, it is our duty and it is our responsibility to find out where is the problem and how to tackle those problems. So, for understanding it is better to divide these complications into these three parts. And what I am going to focus today is patient-related complications. Although it can happen to the, it is quite possible that it could be a cannulation can lead to patient-related, or a technical can lead to patient-related. So let us discuss. We know that the ECMO can be a VV ECMO and could be and can be a VA ECMO. So there
Vinod,
are certain. Sorry, sir.
can you
Yes.
move your slides, please? Slides are not moving.
Is it moving, sir?
No, not yet. We're seeing the title slide only.
Now here to me it is moving. Let me share it again, sir.
Yeah. Now they are moving.
Moving.
Yeah. Thank you.
Is it moving, sir?
Yes.
Yeah. So the ECMO complications can be divided into one which occurs whether we are putting a patient on VA ECMO or we are putting a patient on VB ECMO. It is just related to the patient has put on the extracorporeal circulation, and this could be a thrombosis, a bleeding, a hemolysis, and infection and sepsis. There are certain complications which are related particularly to the VA. This could be oxygenated related like differential hypoxemia. This could be a hemodynamic compromise, elevated distension, and loss of pulsatility. Limb ischemia, it is quite graded complications. And there are certain complications which are related specifically to the VV ECMO, and this could be recirculation and hypoxemia. Now, this is the ELSO data where you can see the complication. It is not specified, the ventilator, patient-related or machine-related. Here you can see the most common complication is renal replacement therapy, requirement of the renal replacement therapy. That could be related to the sickness of the patient. Besides that, the cannulation site bleeding, which is around 12.5%, and the surgical site bleeding 14.5%. Also, if you look at the CNS hemorrhage, it is quite high, 1.4%, and CNS infarction, that is thrombosis, 3.5%. So the complications are not uncommon if you put a patient on VA ECMO, particularly thrombosis and bleeding. So I will start with a case, which is a 26-year-old man with a severe ARDS, which is due to H1N1 receiving VV ECMO, and the venous drainage was with the 25 French long multi-stage or multiple cannula in the right common femoral vein, and also the supply is 18 French cannula placed in the right internal jugular vein. The patient receiving and low VV ECMO, and while reviewing, you find that the patient's oxygen saturation is low, and arterial blood gas also has been done, which is showing the saturation is 80%, which is also consistent with the SpO2 of around 80%. So what we will do, usually we see that the patient has got hypoxemia. We see, look at the fresh gas flow. This is the first step you will be looking, whether you have a correct oxygen supply or not. Look at the blender and look at the flow calibration in your blender. Because These are the machine-related problems which can cause hypoxemia to your patient. Once you have looked all and corrected those things, then you should look at the excess insufficiency, which is the next common cause of hypoxemia. And it could be due to the unstable circuit flow, which could be a rise in negative pressure, which will tell you that there is excess insufficiency. It could be a kinking and swinging of the cannula, and it could be a uh, 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 other causes we will discuss here also. So after looking at the machine, you should look at the excess insufficiency and try to correct the excess insufficiency. Besides these cannula-related problems, the patient-related problem can also cause a change in the preload and afterload and can cause a poor access and access-related problem. And you can see here that a patient who is agitated, if the patient is bleeding and gone into the hypovolemic shock, if the patient has got intense vasodilatation, if the patient has got a tension pneumothorax, which is actually precluding the venous return to the thoracic cavity, if the patient has got a cardiac tamponade, intra-abdominal hypertension, and the cannula clot or malposition. So for hypoxemia, actually, we have to look all these once, first the machine and then is the access related problems. Now, if you have excluded all these access-related problems and still your patient is hypoxemic, the next step you are going to do is increase the circuit blood flow. And you can achieve a circuit blood flow to 6 to 7 liters per minute in adult, you should correct your problem of hypoxemia. If your problem of hypoxemia is not getting corrected and you find that your patient is still hypoxemic, then we have to find out whether there is a overutilization of the oxygen by the body due to sepsis or hypothermia or so many causes, or there is some problem going into the mixing of the oxygenated and deoxygenated blood. And how to fix this problem? You look at the oxygen saturation at the pre-oxygenator, and if you find that the pre-oxygenator has a low oxygen saturation, which is less than 60%, this suggests that your patient is having an overutilization of the oxygen and there is a high patient's cardiac output. But if you find that the oxygen saturation is more than 80%, this is a special problem which is called a recirculation or high recirculation. So if the blood oxygen saturation in the drainage cannula is below 75%, this indicates that there is no recirculation. And if it is more than 80-85%, this suggests that there is a possibility of recirculation. And why this recirculation occurs? Because whatever the oxygenated blood is going in the perfusion cannula or supply cannula is getting sucked out by the drainage cannula, and again there is a recirculation of the oxygenated blood. And this occurs if your cardiac output is the ECMO cardiac output. Sorry, if it occurs because of the positioning. Most common cause is the positioning of the cannula. If the distance between cannula supply and the drainage cannula is less than 15 centimeters, there is quite possible that you might land up in the recirculation. Now, what are the other factors which can affect the recirculation? That could be a pump speed, that could be a blood flow rate, that could be intrathoracic, intracardiac, intra-abdominal pressures, cannula type and size, position, and also, as I told, the distance between the cannula. And what are the interventions required? And first thing, that if we find that there is the distance is less than 15 centimeters, we have to reposition the cannula. Sometimes you have to use a bicaval or dual element cannula, which is shown in this figure. This is a dual element cannula which is placed in the internal jugular vein and has drainage and supply drainage from the IVC and SVC, and supply is directly going to the RA and RB, so it can minimize the recirculation. And you can put an additional drainage cannula which also can minimize the recirculation, and you can also manipulate the reinfusion cannula. Now, if you have excluded that your patient has no recirculation, the next is that your patient might have a high cardiac output and overutilization of the oxygen, and this stage you have to decrease the cardiac output. Usually, in most practical aspects, at least 60% of the cardiac output should be given to the by the ECMO circulation. And if it is less and more patient-related or de novo cardiac output, there is quite high chance that the patient might have a hypoxemia. And you can minimize the patient's cardiac output by using some moderate hypothermia, beta blockers, sedation analgesia. If a patient and if you think that your patient is tolerating the oxygen, low oxygen saturation, there is no increase in the lactate, and there is no hypoxia, tissue hypoxia, we can you can accept lower oxygen saturation in such situation, because the next step is to you might have to go for a other ECMO configuration which can minimize all those things. And sometimes, if you can also increase the ventilator FiO2 to improve the hypoxia. Sometimes, in spite of doing all these things, your patient might have persistent hypoxemia, particularly those patients who has got a severe ARDS, large area of shunt. At this situation, you can try a prone position. There are papers which have shown that the prone position is quite effective, safe in ECMO patient, and might have impact on the survival of the patient. So those patients who are not maintaining on the on the supine position with hypoxemia, we can go for a prone position in such patients. Now, this we have discussed about the hypoxemia on the VV ECMO patient, but hypoxemia may occur in the VA ECMO patient, and how it is different. And look at a patient who has got a 48-year-old man who is supported by the peripheral VA ECMO. He presented 3 days ago with a ST segment elevated MI, a coronary intervention was done. And despite the revascularization, he has a progressive cardiogenic shock and was placed on VA ECMO. And the circuit is running without any problem, but he has now developed a hypoxemia with the oxygen saturation of around 82%. So this patient has also developed hypoxemia, and look at how it is different. So once, whether the patient is on VA ECMO or VT ECMO, if the patient has got a hypoxemia, look at the machine, look at the patient, and try to find out in VA ECMO particularly, is there pulsatile flow or not, whether the patient has got oxygen saturation measure, which is right hand and left hand, is the patient has got a pulmonary dysfunction associated with cardiogenic shock, whether the patient has got a ventilator sitting, which is appropriate, and also, after looking this, look at the ECMO, is the patient has got the blood flow which is adequate for the patient, and that means adequate ECMO support. And is the oxygen is delivered to the oxygenator, that again the machine related problem. So basically what I'm trying to emphasize here is that once the patient is hypoxemic, try to look at the patient, try to look at the machine, and try to fix the problem. Whether the patient is got a problem is related to the patient, or whether the problem is related to the machine. Now, in this, again, the same patient, we find that the patient has got a femoral peripheral VA ECMO configuration with the cardiac, with the ECMO flow of 3.5 liter in the last day. And the oxygen saturation in the right arm is showing that right thumb, the right finger showing the 82% measure, and the 99% on the left side, 100% oxygen is getting connected to the patient. And there is a very good pulsatility to the patient. That means the pulse is visible, and in the arterial line, there is a good pulsatility. And you find that the oxygen saturation is also, patient is pre-oxygenated oxygen is 75%. That excludes the oxygen consumption related problem. So in given this situation, you find that the left-sided saturation is okay, the right side is 82%, also the overlaid saturation is low. This is particularly happens in patients who has got a VA ECMO support, and this is called Harlequin syndrome or differential hypoxia. And you have to find out or treat it. If you're not treated, the patient will have a cerebral damage, coronary damage. You can see how it is possible. If you look at here, this is how Harlequin syndrome can be described. This is a situation specifically occur in patient who has got a native lung function which is very good, has improved, but the native heart function which has improved, but the lung function has not improved, and that leads to a mixing of the blood cloud, which is oxygenated and deoxygenated blood. You can see here they are mixing. And if the patient's cardiac function is okay, then there is quite possible that the deoxygenated blood is coming to the upper part of the body, while the oxygenated blood which is going through the ECMO support may not reach to the upper part of the body, and that can lead to occurrence of the this differential hypoxemia or Harlequin syndrome. You have to diagnose it, you have to pick up it, you have to manage it. So how to treat and how to fix it? If just the ECMO setting. If you have a high flow, you can use a high flow. You can also go to modify the ECMO configuration. You can go a VAV ECMO. And sometime also what you can do, you can, if you find that there is no need for a cardiac support because the cardiac function is improved, you can just convert it to the VV ECMO, and that will solve the problem of this mixing. So once recognized, you can manage according to the patient's need. You can go for a VV ECMO or you can go for a VAV ECMO in such situation to minimize the north-south syndrome, but it is important to pick up early. Now, infections during extracorporeal membrane oxygenation. This is the most dreaded complication, one of the common complications besides bleeding, which can kill the patient. And the prevalence in the hospital-acquired infection is almost around 10 to 12%, and likely more frequently if the patient has critically ill and long duration of ECMO support. And the risk was increases with the duration of ECMO support. How to find out? If the patient has got a new hypothermia, if the patient has got a hypotension, if the patient is desaturating, that means the more oxygen consumption, purulent tracheal secretions, frank pyuria, fall in the renal output are requiring renal replacement therapy since serum and blood culture is positive. These are suggestive that a patient might get a hospital-acquired infection or a new infection. And as you know that most common organism it depends upon the hospital microbiomic data, and it could be a candida, it could be a streptococcus, which occurs more in critically ill patients, could be a pseudomonas, could be a other gram-negative infections. So once you have this type of infections, the management is similar to most of the ICU patients. What is required is the highest dose of antibiotic because of the antibiotic may get stuck with the membrane and ECMO cannula, so we need the highest dose of antibiotic. And also we need to have a prolonged duration of antibiotic therapy in such patients. Second, whether to change the membrane or to change the cannula or not, this is a quite challenging situation, and it is totally dependent upon the ECMO specialist to what to do with the if these systems like oxygenator gets colonized with the particularly with the candida and repeated candida culture is coming positive. Now the second situation arises, you are putting a patient on ECMO and you find that the patient's endotracheal tube is coming with a pink fluid. That means the patient has got a pulmonary edema, not able to ventilate, and the patient is getting pulmonary edema like picture, and pink fluid is coming from the endotracheal tube. Look at a patient who has got a 39-year-old male who is connected to peripheral phantom VA ECMO, and the patient has got a flow of 3 liter. On the second day, it becomes progressively more difficult to ventilate. And you find that there is a large volume of pink fluid is coming to this patient. What is happening to this patient? It is very important to recognize this complication. And if you look at, I think this video is not moving somehow. Yeah, now it is moving. So if you look at this transverse echo which has been done, you find that the patient's left ventricle is distended, it is not moving, not contracting, and that leads to development of pulmonary edema, which is seen in the picture. And this is very common finding in VA ECMO if your patient's cardiac output is very low, and if the patient has got a severe myocarditis or a complication of HTMI. So what to do in this situation? What acutely you can do as a specialist, you can increasing the PP reduces the stress to the LV and may further reduce the LV payload. So if you want to decrease the pink blood flow, don't go to increasing the peak. That will might precipitate more and more pink fluid. So what you can do, you can increase the inotropic support in such situation. You can also go for an intra-aortic balloon pump, and you can go for a LV venting. Most of the time, you start for a conservative treatment. That means you can slightly decrease the ECMO support, and if you go for a IABP in such situation to have the good inotropic support also to the heart so that the contractility should be increased. This is one way of managing this pulmonary edema. If the patient has no pulsatile flow and the patient's pulmonary edema has been worsening, we can, and if you echo, you find that the patient has got airway distension, there is no aortic valve opening, then and you find that there is a, you can go for decreased MAP and decreased ECMO flow, and also you can increase the inotropic support or IABP. If there is no improvement, we might have to go for a cardiac intervention, and that is LV, LS septostomy or direct LV drainage, or you can go for an implant. So most of the time, what we have found that it is a conservative treatment with which the patient improves, but if the patient is not improving, then we might have to go for intervention to decrease the LV distension. Again, here we can see a third situation. Look at a patient who has got a VAP, and the patient was sent to the ICU after PCI and with a occluded LAD lesion. And 2 days later, there was a sudden threefold increase in the vasopressor requirement, and the patient's arterial line trace has gone from the first. You can see here there is a pulsatile flow, and after 3 days, the flow has become non-pulsatile. So, what to do, what to think, and how to manage. So, if this complications occurs from a pulsatile flow to non-pulsatile, you can think the patient has got a pump failure, or the patient has got a hypovolemia or bleeding, or the patient has got a cardiac. If we try to fix this problem, you have to have a very systematic approach. If you look at the signs of pump failure, the patient will have a low ejection fraction, the chamber size might be distending, the valvular dysfunction is there, there may be large regional wall motion problem because of the new onset of some cardiac problem. If the patient has got a tamponade, the patient might give
Vinod,
you,
slides are not moving.
is it moving, sir?
No.
No, no, it's immediately what is happening. Is this?
No.
We can present the slides from here. He can say more music. We can project the slides from here if you want.
Can we project the slides from here?
Yeah, yeah, you can do, sir. If there's no movement, you can do it here. Is it moving, sir?
Not moving.
Mhm. Just a minute, sir. Just a minute. Now, sir?
Now moving.
Yes, now moving.
Okay, now you have to. Okay, sir. Okay. So I was here. Sorry for technical problem. So, if the second part of the look at and to find out to fix the problem of loss of pulsatility in a VECMO, you have to find out whether the patient has got a cardiac tamponade, or there are signs of tamponade like if in transthoracic echo. If you find that the patient has got a pericardial effusion, if the patient has got a systolic cardiac collapse and the RV collapse, or if you find that the patient's all the signs of the cardiac tamponade. Sometimes it's not possible to find out in transthoracic echo. We might have to go to transthoracic echo to fix this problem. The other signs or other problem is due to hypovolemia or bleeding, and we can find in the transthoracic echo the patient has got a small LV cavity, a hypercontractile LV, or the LVOT and DTI is less than 12 centimeter, a collapse IV. These are the findings that the patient is might bleeding somewhere and the patient is hypovolemic. So also you should try to fix this problem. Now the other complications which already Samir has talked about, the bleeding complication, which is the most bleeding and thrombosis complication, which is also a graded complication. The reported incidence is the cannula side is 17%, also the intracerebral bleeding is 15%, and also thrombosis. It could be a pulmonary thrombosis or some other areas of thrombosis, which is 19% reported. And if you look at this picture, you can see that the patient has got intracranial bleeding, and it is reported 1.8 to 21% in different literature and different type of ECMO support, whether it is a VA or VV ECMO. And there are certain factors which are responsible, like if the patient has got a long duration of ECMO, if the patient has got a rapid hypocapnia, that means if the patient, we have put a patient for VA or VV ECMO and the patient's PCO2 as high, like more than 100, and you have decreased very rapidly. These can cause a change in the a rapid change in the PCO2 and can cause a decrease, can cause a intracerebral hemorrhage in such situation. And also, if you have a hyperoxia, that has also been correlated with the intracerebral hemorrhage in such situation. Now, what to do? This is a quite challenging whether to continue ECMO support or discontinue the ECMO support. Most of the time, it is the anticoagulation has to stop. And if the patient is VA ECMO, then you do not have any other option than to discontinue the VA ECMO support because of the you have to stop the anticoagulation. In VV ECMO, you can continue without heparin if you maintain a high flow. And the ELSO registry, 11% of the patients in VV ECMO and 26% of those in VV ECMO who developed ICH survived to hospital discharge. That means if we are taking care in early stage, that the patient can survive and the patient can be discharged also, but these numbers are very, very low and very unlikely that the patient will go out of the hospital. So other complications are the vascular complications and the limb ischemia. This combination of the femoral arterial subcannulation in the VA ECMO, and because the patient has got a hemodynamic compromise and hemodynamic instability, these complications are more common, and the risks are greater with a larger cannula if you are using a more than 20 French for VA for femoral arterial, and particularly in women because their artery size is low, and also the clinical presentation varies in severity from pain to failure to poikilothermia and the motor and sensory deficit. Doppler ultrasound and near infrared, the NIRS, is quite a good and sensitive mode for recognizing these complications. And the placement of digital perfusion catheter actually has decreased and minimized these complications. If you look at the NIRS, which is should be 50% above 50% by predicted and 60%, that means there should not be a more than 20% difference between the normal between the those who are catheterized with the artery and those who are and the limb which is not catheterized with the artery. This is the two extremity 20% difference is the required for prevention of this.
Vinod, can
And
you fasten up a bit?
sorry, sir. This is
Yeah.
and this is the how the picture if the patient has got a problem with the ischemia. Vascular injury, already we have discussed that there is a 10 to 14% chances of vascular injury in patient who has got due to cannulation site injury occurs. This is important complications like patient has got a hemolysis. If you find that the ELSO guideline says that if the plasma hemoglobin is should be kept less than 1%, any time it is less than 0.1%, any time it is more than 0.5%, 0.5 gram per dl, there is a quite possible that the patient will have the hemolysis. And this there are several causes like if the patient has got a pump thrombosis, oxygenation thrombosis, patient has got a excess insufficiency. All these can cause a hemolysis and rise in plasma hemoglobin, which can produce a DIC-like picture. So my take-home message is that if the patient has the hemorrhage and infections are the two main complications related to the ECMO. Arterial cannulation is related to higher risk of bleeding. The hemorrhage occurs in the any organ with the intracerebral bleeding being most devastating, and the pathogenesis of thromboembolism with ECMO is multifactorial. The ECMO management includes close coagulation monitoring, ensuring the best possible balance between coagulation and hemostasis. Infective complications can be related to the indwelling lines, excess site, primary pathology. Strict aseptic handling is required in patient with ECMO. A distended, non-contracting left ventricular echocardiography requires urgent intervention, and hypoxemia and ECMO should be approached systematically to minimize the patient's rate of complications. Thank you very much for your patience.
Thank you, Vinod. Any questions? So there are some questions.
Yeah, sir.
Good morning, sir. My question is, how is hypoxia management in VA ECMO specifically different from hypoxia management in VV ECMO? Was there any special point to think over?
No. See, hypoxia management in VV and hypoxia management in VO is not the problem. Problem is try to find out the cause of hypoxia, because in VV ECMO, one of the cause of hypoxia is recirculation. Okay, so that requires a different attention. In VA ECMO, one of the cause of hypoxia is the Harlequin syndrome or differential hypoxia. So these are totally different kind of management required for all these patients. So what I'm trying to emphasize, if you have a patient with hypoxemia who is on ECMO, you should try to find out what is the cause of hypoxemia and try to fix the cause. It may not possible to manage the hypoxia just by increasing the flow. It may not possible to manage the hypoxemia just by increasing the FiO2 in such situation. So unless and until we try to fix the cause, it is quite impossible to solve the problem of hypoxia, whether the patient is on VA or VV. And I have told what are the causes and how to find out and how to fix the problem. Like if you have an excess problem, it is quite simple to manage whether the patient is in VA and VV. But if the patient has got a VA ECMO and then the patient has got a differential hypoxia, you need to have a different approach. If the patient is VV ECMO and hypoxia and it is due to recirculation, you have to have a different approach.
So, like I was asking you, like you specifically mentioned both man and the machine in VA ECMO. Like, is it?
Yes.
So
Yeah, man and the machine. Because if you look at the hypoxia in the VA ECMO, if the patient has got a differential hypoxia in such situation, this could be because the cardiac output has improved of the patient. Okay.
yes, sir.
And the lung condition has not improved. So the native circulation is good, but native circulation is a hypoxemic circulation because it is not getting oxygenated in the lung.
Yes,
Okay,
sir.
so what you have to do, there is no need to continue with the VA ECMO in such situation because it is creating harm to the patient.
Yes,
If the lung circulation, if the native circulation is improved, just convert into VV ECMO. The patient will be all right. Or what you can do, you can have another cannula and put on the oxygenated blood in the internal jugular vein, so that some of the oxygenated blood is going to the internal jugular vein, and then oxygenated blood is going to the cerebral circulation. Got my point?
Yes, sir. And you mentioned about loss of pulsatility algorithm. So when is
Yes.
that? When is that important? Is that important during weaning phase?
No. This is not important during breathing. This is important during the ECMO support phase. If you had a good pulsatility while you started the ECMO, or if you have adequate pulsatility, and suddenly you find that your arterial pulse is not there, that means your forward flow has gone down. All the patient will maintain the circulation, but something has happened in the heart.
Yes.
Whether it is a loss of the pump function, whether it is a loss of the adequate preload, and whether it is a contractility has decreased or some cardiac tamponade which is caused it. So you need to fix this problem.
So when the
That means you cannot keep quiet that okay, my ECMO is getting the supported by the ECMO circulation, and my patient is getting supported by the ECMO circulation. But if the pulsatility has got down, that means the heart will not recover.
right.
Got it?
Yeah. Thank you, sir.
Sir, my question is, suppose if a patient of DCM with very low ejection fraction, comes to the emergency, got CPR, intubated, and on the next morning, if the blood reports come like high WC count with, with high procal, should ECMO end with high inotropes definitely. If that patient put on ECMO, should his infection flare up, or should he consider ECMO for this patient in an already infected or suspected infected patient?
See, ECMO has nothing to do with the infection. Try to keep your mind. Even the patient is in septic shock. Septic shock is a vasodilator shock, but if you find that the patient of septic shock has a cardiac output is very low, like ejection fraction is low, 20-25%, this is the typical patient who should go for ECMO. We know that there are two types of septic shock. One is the hyperdynamic, when the patient's cardiac output is okay and the patient's cardiac output is 8 to 10 liter. These are not the candidate for the ECMO. But if the patient is septic shock with the cardiac output, very cardiac output low, and the patient's ejection fraction is low, for transient, they can go for a support with it. Similar things will apply to your patient also. Your patient has got a DCMP cardiomyopathy. And if the patient has got some infection or somewhere, but if your patient's cardiac output is low, and if you have an option for the definitive treatment, if it's DCMP and if you do not have the option for definitive treatment, then ECMO may be a futile in this situation. But you have some option in your mind that a transplant or something later on when the patient has improved, then the patient should be put on the ECMO. Only problem is the patient has a multi-organ failure. Any question?
If there are no questions, then we'll move to next session. Thank you, Vinod.
Okay, sir. Thank you, sir.
Thank you, sir. Our next talk will be on mechanical complications on ECMO by Dr. Nand Kishore, sir.